is Dr. Saroj Gupta, and the paper is Clinical Features and Management of Acute Unilateral Proptosis After Blunt Orbital Trauma.
So very good morning to respected judges and all present here. So I'm going to present one of my paper on clinical features and management of acute unilateral proptosis following blood hand injury. So blunt orbital trauma can give rise to sudden acute proptosis in young patients. They require immediate evaluation to delineate the cause of proptosis and rule out orbital fracture with the associated. Visual impairment occurs either due to optic nerve involvement or due to exposure keratopathy in case of severe proptosis. Therefore, early diagnosis and management is very important. So this is my retrospective study on the clinical features and management of series of patients presenting with acute proptosis following blunt orbital oblique head trauma over the past 2 years at a tertiary care center. So there were 4 patients in the series, age group of 12 to 16 years, presenting features were ipsilateral protrusion of the eyeball following blood head or orbital trauma in all these patients. So first was a 13-year-old child presented with protrusion of the left eye with redness, pain, dimness of vision for past 12 days. So there was a history of blunt trauma due to fall from a vehicle. Vision in affected eye was hand movements. There was abaxial proptosis with leg ophthalmos with severe exposure keratopathy because patient presented very late, about 12 days following injury. And in the center, there was a large ulcer with irregular margins, with brownish pigmentation over the surface with a streak of hypopyon. So we did a macrobiological workup for the ulcer. So KOH mount showed a septed hyphae. SDA culture showed a woolly growth with black pigment, and LPCB mount showed a septed hyphae with brown conidia. So based on these features, it was identified as Carularia lunata. So it's a pigmented fungal, which is not so common in exposure keratopathy. Then we did a CT scan to know the cause of proptosis. So there was subfrontal extradural hematoma as well as superior orbital subperiosteal hematoma was there. So 2 hematomas were there, but there was no any fracture of the roof of the orbit. Then after making diagnosis, we did a USG guided aspiration of this hematoma was done with 18 gauge needle on syringe. And this needle was passed transcutaneously through the superior orbital space, lateral to the suborbital march. This was done under USG guided, and we aspirated the blood around 11 ml, which resulted in immediate resolution of the proptosis as shown in the figure. But patient had exposure keratopathy, so we did arthrophy also after that, after doing the aspiration of the hematoma. We treated Carularia keratitis conservatively with the antifungals, and antibiotic drops were given. A therapeutic scraping was done, and at the 6-week follow-up, patient had a good healing of the ulcer with a leukomatous corneal opacity. We did a follow-up scan also at 6 weeks. So the extradural hematoma was treated conservatively, it absorbed, and the orbital hematoma was drained, thus the patient was managed. Another case with 12-year-old boy presented in emergency again with sudden proptosis of the left eyeball following collision with a wall. Patient presented in 2 days. Affected eye vision was 612. USG orbit again showed orbital superior suborbital hematoma was there. So again, in the same way, we did USG aspiration, guided aspiration of the hematoma with a needle, and we aspirated on 18 ml of blood. And this resulted in immediate reduction of the proptosis as shown in the figure, on table only. Case 3 and 4, similar 16-year-old boy presented with history of fall from his bike 4 days ago, had an axial proptosis, had a similar superior suborbital hematoma. And the 14-year-old girl also had a RTA and had a axial proptosis. A similar picture was there. So in both the cases, again, we did a USG guided drainage of the hematoma, resulting in relief of proptosis. These last patients present immediately, so didn't have exposure keratopathy like in first case. So orbital hematomas are rare. They are either superiosteal or intraorbital in location. Orbital subperiosteal hematoma typically results due to blunt trauma in the head region, although there are cases of spontaneous hematoma also in the literature. The common site is usually orbital roof because there the periosteum is not firmly adherent to the bone and in the children, and therefore this hematoma is common in children following trauma. And visual impairment occurs either due to compression or stretching of the nerve in the orbit or due to severe exposure keratopathy like in our first case. So CT scan is the preferred modality to delineate the size and extent of this epidural and subperiosteal hematoma, also with the fractures. Management could be either observe if it is a small hematoma not giving rise to much symptoms or signs, or needle aspiration can be done, or surgical evacuation may be required if the aspiration, we are not able to evacuate or aspirate the hematoma with aspiration, we may have to surgically evacuate the hematoma. There are few case reports of following hematoma, superior hematoma following blunt trauma. And Kim et al. Reported a case series of post-traumatic orbital hematoma, but there was a dry aspirate, so they treated with systemic steroids. So to conclude, superiosteal hematoma of the orbit must be considered in differential diagnosis of unilateral proptosis following blunt head trauma in children Needle aspiration is a very simple technique that helps to resolution of the proptosis immediately in leg ophthalmos and prevent exposure keratopathy. And macrological workup is important in case of severe exposure keratitis, so as you can manage the keratitis also. This case we have published in case reports published in IJO also, and this is the first case of corollar keratitis and exposure keratopathy which we have published. Thank you.
And what is the visual acuity improvement in these patients? What is the visual acuity improvement in these patients?
Vision improved in last 3 cases because they presented immediately, but the first kid has exposure keratopathy and had a corneal ulcer, so we have registered for keratoplasty.
And this orbital hematoma, there was no associated fracture of the roof.
Sir. First patient has epidural hematoma also, but they absorb spontaneously. We considered neurosurgeon also. They said no need for drainage, and it absorbs.
Yeah, he was moving about for 12 days without any symptoms
we did
actually.
but orbital hematomas were aspirated with a USG guided aspiration.
So that's the normal USG which we use for ophthalmic purposes.
Yes, normal USG. So we did a guided aspiration that we reached the hematoma only.
Thanks.
Thank you.
In your first case, it looked like endophthalmitis.
No, madam.
Yeah, because there was lot of keratitis. The patient presented late. There was lot of, congestion. The proptosis was there. Is it safe to do an aspiration under those conditions?
Madam, we did USG, so there was a clear hematoma could be seen with well delineated margins. So we did an aspiration and it resolved immediately. The proptosis also resolved. And then the ulcer was treated with an antifungal antibiotic, and 6 weeks also healed completely with a living corneal opacity. So we are following this patient. Still patient has PLPR accurate. So we are planning for, and B scan was also done because you could not see the posterior segment. So B scan was clear, vitreous was clear. So now patient is waiting for the PK.
And what gauge needle do you use
18
for
gauge needle, madam.
18
18
gauge
gauge needle.
Okay.
Yeah. Thank you.
Thank you. Any
Thank you,
questions?
ma'am.